Hey, what's up, and welcome to world number 5 of Power Up Endo's 90-day Super GP training program. I hope you really took a lot of value out of the lower molar live case demonstration. That's going to be the first of many molar teeth that I've prepared for you to be able to follow step by step and really learn how to apply the Power Up Endo framework into clinical applications over and over again to get you more and more comfortable with endodontic treatment and how to apply it in a clinically relevant and practical manner in your general practice. This entire world is dedicated to how I want you to think about and administer what I like to call bulletproof anesthesia. That's rock solid anesthesia that you can depend on to get your patients predictably numb so that you can do your endodontic work or any dental work for that matter without the worry that they're having discomfort and without the stress that you're hurting your patient and potentially giving them a bad experience. In this world, I'm going to show you some of the techniques that I use in my clinical practice, and also I'm going to show you step by step how I want you to anesthetize your patients for endodontic treatment or any invasive dental treatment for that matter. So without further ado, let's get into it. This is level 1 of world number 5, all about bulletproof anesthesia. Here we go. First and foremost, okay, there's no messing around in endo, okay? You have to have a very, very high level to perform bulletproof anesthesia and to get your patient profoundly numb for what is considered to be a fairly invasive dental procedure. So you can't get away with the same level of anesthesia as when you're doing potentially a shallow composite restoration or maybe even an SRP. You need your patient absolutely numb in order to get into the pulp and do what you have to do for them without them feeling any pain. I'm going to show you exactly how to do that. Also, you have to be mindful that once the patient starts having some discomfort, there's a feedback loop of anxiety that's going to occur. Once they get to that point where they become hyper excited because of an instance of pain, it's hard to make up ground because now you're fighting an uphill battle where the patient is going to be like squeamish and squinting anytime you go ahead and make a maneuver along the endodontic procedure. You want to be sure that the patient's numb before you start working on them, obviously. And also, for your own peace of mind and your own level of stress, you want to get your patient numb and comfortable so that you're not on guard and worried that you're doing something to the patient that's going to cause them pain and potentially give them a bad experience, and hopefully it doesn't lead them to leave an unfavorable review on your practice online. And so these things are super, super important. You have to be really confident in the manner in which you provide anesthetic, especially for invasive procedures like endodontics. And there are a bunch of techniques out there. What I'm presenting to you is what I consider to be the most predictable way to get your patients anesthetized for endodontic procedures. Now, I'm not going to get into the minutia in terms of the mechanisms of anesthetic. There are entire textbooks dedicated to topics like that. I'm going to be presenting to you the most clinically relevant way to anesthetize your patient without getting too bogged down into the minutia. Just what you need to know. This is a course with a ton of information. I'm not going to fill it with a lot of mechanistic formulas and theory. Only what you need to know, only the most clinically relevant information. And so, first and foremost, very frequently I get patients tell me, that I should, after I do my procedure, teach their doctor how to get them adequately numb for all types of dental procedures. And there's oftentimes patients in my schedule who have just had a prep and temp appointment with their dentist, and they claim that, they had so much pain during the prep and temp, and that might have been one of the reasons that the general dentist thought that maybe they need endodontic treatment, which they may or may not. First, we're going to do our consultation, but regardless, they probably shouldn't have been experiencing that level of pain, right? So endodontists themselves are generally very good at achieving profound anesthesia on their patients because we have to be. Patients can't be, you can't get through an endodontic procedure with a patient who's squeamish, especially at a high level, especially back to back to back, like endodontists tend to schedule. We, by nature of having to, generally get pretty good at administering anesthesia, and I'm hoping to pass along some of that information and that wisdom so that you can become more confident in getting your patients fully anesthetized. Again, whether you're providing endodontic treatment or any other invasive dental treatment. I even had general dentists that would send their patient to me to anesthetize them, only to send them back in order to perform some sort of restorative visit or whatnot. And so this isn't about me. I'm just trying to make you aware that endodontists generally have a good handle on getting patients anesthetized, and that's what I'm trying to pass on to you. And the truth is, technique is obviously an important factor, but just as important as technique, the type of anesthetic that you're using, as well as the amount that you're using, is very important. So we're going to discuss that a little further. There are some rare exceptions, obviously, where there are difficulties in getting a patient numb for endodontic treatment. Usually I found that that has to do with anxiety. That's the most common exception. When we get into a situation where I'm attempting to anesthetize a patient and we're having some signs of anesthesia, but I'm not able to confirm that they're adequately anesthetized with my cold tests, or we think that they're anesthetized, and even with supplemental injection techniques, they're still having discomfort. This can happen, and this does happen maybe 1 out of 200 times that I see a patient for endodontic treatment. And usually the way that we manage a situation like that is we tell the patient, hey, we don't want to harm you. We want you to have a pleasant experience. Why don't we reappoint you and have you take some medication prior to your appointment so that we can attempt to work on you in a more relaxed state. And so what I do in those situations is I pre-medicate that patient with some sort of analgesics. And I like to have them take 600 milligrams of ibuprofen along with 2 extra strength Tylenol. That way we can have a lowered threshold before we start anesthetizing and ultimately working on our patient so that they're more comfortable. Does that analgesic do the trick alone? Potentially. Also, another factor could just be that they're more calm after having come to the office now a second time. They're not so worked up. And also they're made aware and they understand that if we're not able to get you adequately numb, we can't perform endodontic treatment for you. And therefore, not every tooth is a candidate for endodontic treatment, right? If we can't get you numb and work on you, you may want to consider dental extraction because it's a much quicker procedure than sitting through a 30, 45 minute, up to maybe even an hour visit for endodontic treatment. Usually the combination of those things where they don't want to lose their tooth and they're there a second time, so their anxiety is a little bit lower, along with the analgesics, gets them through the appointment. There's been maybe 1 patient that I can recall out of the thousands of cases that I've seen that just was not a candidate for endodontic treatment because we couldn't get them, consistently, adequately anesthetized for endo. This is very, very rare. And now, in terms of the type of anesthetic that I use, that I would recommend you use, granted, you're a doctor, you can use whatever you want. I have just found that Articaine is a significantly better anesthetic than lidocaine at achieving profound anesthesia for invasive dental treatments like endodontics. And this has been hashed out. Now, Dr. Malamed has talked about this over the years, and this has been a hot topic in dentistry, right? But when you look at systematic reviews, it has been consistently shown that on lower first molars, which is kind of the benchmark for how well an anesthetic will work, lower first molars that have symptomatic irreversible pulpitis, the anesthetic that can most consistently get that patient anesthetized and ready for endodontic treatment has been found to be Articaine. You have to remember that just as important as technique and quantity, the type of anesthetic you're using is also very important. And so the reason, knowing that, I will always use Articaine for all of my local infiltrations, all of my mandibular blocks, all of the anesthetic techniques that I employ on patients. The backbone of that is Articaine. Now, obviously, Septicaine, which is Articaine with epinephrine, does have epinephrine included in it. And so if a patient can't receive epinephrine for whatever reason, then we modify that and we use, an anesthetic without epinephrine, which, as you all know, is usually carbocaine or mepivacaine. Generally speaking, though, if a patient can receive epinephrine, I always reach for Articaine, also aka Septicaine. Now, it's been debated for a long time whether this anesthetic, Articaine, can lead to rare instances of paresthesia. And again, this has been hashed out as well. But generally speaking, paresthesia is rare no matter what kind of local anesthetic you're using. It's been shown that it's a negligible or a statistically insignificant difference in terms of the paresthesia on patients, whether they use xylocaine or Septicaine. It's a myth and an old wives' tale that using Septicaine for your mandibular blocks, let's say, will lead to an increased level of paresthesia or an increased chance of paresthesia. In terms of maximum dosages, you're never going to get close, you shouldn't, to a maximum dose unless you're dealing with a cardiac patient, because the vast majority of the time, you're going to only need 2 cartridges of Septicaine in order to get your patients fully anesthetized, unless you're going to be employing a supplemental injection technique, in which case you might be using 1, at most 2 more cartridges, right? But you're never going to get close to those maximum dosages. If you're starting to, something's not right. We're working in such a small area in endodontics, we don't need to use 5, 6, 7 cartridges of anesthetic, unless, maybe you're doing apical surgery on, many teeth. That's a different story. Like I mentioned, if your patient can't receive epinephrine, obviously we're going to be using an anesthetic without epinephrine. I reach for carbocaine in these instances, which, as you know, is mepivacaine. And you're not going to get anywhere near that maximum number of cartridges. If you're working on a lower posterior tooth, you're going to give your mandibular block or your Gaugates injection with a full cartridge and maybe 1 more cartridge in terms of a buccal infiltration. But you're not going to get anywhere near 9 cartridges, right? So 2 cartridges in the vast majority of cases. And in terms of the technique, which I'll demo for you later on in this world, but in short, like I mentioned, you only need 2 cartridges for the vast majority of your endodontic cases. So for maxillary teeth, you're going to obviously use a short needle, and you're going to administer 1.5 carpules on the buccal, and then you're going to give a half a carpule on the palatal. Palatal anesthesia is very important and often overlooked, but it sets up the patient for a much more comfortable endodontic procedure, and I'll explain to you why shortly. For your mandibular posterior teeth, obviously you're going to use a long needle, and what I'm recommending is that you administer a block in the form of a Gaugates injection with 1 full carpule, obviously after a negative aspiration, and then you're going to administer a full carpule in the form of a buccal infiltration. That's going to cover you for the majority of your endodontic cases, unless you're having something going on that requires a supplemental anesthetic technique. And then for your mandibular anteriors, clearly you're going to use a short needle. I want you to deposit 1.5 carpules on the facial and then a half of a carpule on the lingual. And that's really meant to make the rubber dam isolation more comfortable for your patients, because oftentimes, as you know, you don't have much of a cingulum on those lower anterior teeth, and so you usually have to grab a little low on the crown of the tooth in order to get the rubber dam to properly hold and potentially pinch some of the gingival tissue. And then finally, if your patient requires supplemental anesthesia, let's say you have a patient who has a really hot tooth, the supplemental anesthetic techniques that I'm going to be teaching you are two. First, the intraligamentary or PDL injection technique, which is a fantastic technique. I'm going to show you exactly how to do that. But essentially what you're going to be doing is you're going to be bending your short needle and inserting it into the periapical tissues around the tooth, and you want to insert that needle quite deep into the periodontal space. It should be deep enough that it requires a ton of force with your thumb in order to deposit the anesthetic, and it's going to cause considerable blanching of the gingival tissues. That's how you're going to know that you've deposited in the right spot. You've got a lot of blanching, and it's very challenging to depress that thumb ring. And it really should only require a tiny amount of solution in order to cause all that blanching that you're looking for. And then secondly, as you're making your way into the pulp space, once you have exposure of the pulp tissue, if your patient's still having a little discomfort, that's when I want you to employ an intrapulpal anesthetic technique. Or again, you're going to take your short needle bent at 90 degrees, you're going to insert it into the pulp, the patient might feel a little bit of pressure, and you're going to deposit half to a full carpule of anesthetic directly into the pulp tissue. That will always get your patient numb. Sometimes if a patient has like 1% of discomfort still, and I can tell they still feel a little bit, I frequently say, hey, what I want to do is I want to just make a quick little zip right into the pulp tissue, and once I do that, I'm going to be able to flood your pulp or your nerve with anesthetic, and that's going to get you 100% numb. And it does, 100% of the time. That's going to do the trick to get your patient fully anesthetized. I'm going to go over more details, but I wanted to give you this brief overview before we get into the nitty-gritty. So there you have it. That is the introduction to what I call bulletproof anesthesia, and it's kind of the groundwork before we get into more of the nitty-gritty. I'll see you in the next lesson.